Well, thank you, Professor Blanche, for speaking with us and agreeing to talk about dead space as a clinical and prognostic indicator in ventilated critically ill patients. It's an honor to have you here, and please take it away.
Okay, so then I start. First of all, thank you very much. To speak about data space. That's well, to me that is an opportunity to revisit. This great topic and see. What's going on. So thank you very much. So my first slide is my conflict of interest. I am inventor of a couple of patents related with monitoring of signals. And also I am founder of an spin-off, which is a research and develop company of my institution, Park Townley. So I would like to speak first about some physiologic principles regarding, in that case, data space. And I take that slide from the Wear Mate article in New England to describe here. Can you see my mouse?
Yes, we can.
Okay, yes. Thank you. To see that when the context of lung dysfunction, in that case due to a radius, the normal lung structure, evolves to a structure where there is alveolar occupation, and also there is some endothelial damage and also damage in the interstitial spaces, and this causes, data space or causes CHAN. And in that condition, there is, alveolar spaces are filled with exudates, there is loss of lung volume, and then there are severe acute hypoxemia, and these are the factors: neutrophilic inflammation, pro-inflammatory cytokines, physical stress induced by ventilators. Now, there is a lot of, papers and reasoning at the bedside about oxygenation and the derangement of oxygenation, but it's not as common to talk at the bedside about data space. So to summarize, data space represented in this lung model of three departments, it's the following. If we have an alveoli, okay, which is occupied or it is obstructed, but it is well perfused, this is a pure shunt component. When we have an alveoli, when there is an emboli in the supplier, but it is ventilated, then we have a pure data space, in that case, component. And the data space is composed of two, and this is very important because maybe we cannot do something on alveolar data space, but we can do, specific things in the ICU on anatomic data space, which is, it is composed of instrumental and airways data space, and these two, form the physiologic data space. And this is a normal, in that case, alveoli. When there is an RADS or a COVID-19 related RADS, usually these two, there is a combination of data space and CHAN that account for the, in that case, of the decrease in the alveolar ventilation, increase in PaCO2, and also for the hypoxemia. If we go at the bedside and we have a tracing of flow, and in that case PCO2, it is what a capnograph, this is as a function of time. Any capnograph can give us this type of tracing. We must distinguish two waveforms. This is at the airway, what the PCO2 is, and there are four phases well described. This is at the beginning, well, you will see here, this is inspiration, this is at the beginning of expiration, and then if it is normal entitled CO2, it's alveolar CO2, and the difference is maybe a couple or 3 millimeters mercury. In case of a low, in that case, BQ, where there is poor ventilation but good perfusion, this increases, and when there is a high BQ due to, in that case, an impairment in perfusion, usually the entitled CO2 decreases. But this is what happened at the alveoli, and this is what happened in that case at the airway. Also, the PCO2 can be plotted as a function of volume, and this is what do some capnographs, and then the shape is more or less the same during expiration. I mean, the exhale volume, the first volume is free of CO2, and this is the transition, I mean, from this free part of airways of CO2, when in that case alveolar air is getting, I mean, the airways. So it's a transition between phase 1, phase 2, and phase 3, and this is normal because there is these angles, these well-shaped angles indicating that this is normal, and end-tidal CO2, it's close to PaCO2, and this is the effective alveolar ventilation. This can be also recorded at the bedside. The capnographs can work either as a function of time or as a function of volume. When we describe specific situations at the bedside, I mean, again, this is normal, normally ventilated and normally perfused, and when it's in that case an vascular obstruction here, I mean, and there is no anatomic or geometrical alteration in the airway, simply the shape is the same, but the end-tidal CO2 goes down. This is ventilated but not perfused. This is indicated. And it's interesting because in the past, and maybe this has implications for COVID-related RADS, as I will comment later on, when there is a pulmonary emboli, there is a profound alteration of the PaCO2 as a function of volume. This is an old paper from intensive care showing that when there is this massive emboli, despite increasing the expiratory time, end-tidal CO2 do not go up because there is that stopping perfusion. And then in B is 24 hours after the fibrinolysis when the perfusion is restored, and also this restores to normal. Therefore, it is again is a physiological marker indicator that together with the other parameters that we have at the bedside, it tells some important physiologic information. This is just to say that this is a postmortem RADS lung arteriographic patterns, and this is a patient with a RADS, and we can see, I mean, the alteration in these small vessels, probably inducing, I mean, the dead space participation in a RADS besides of shunt. This is pure alveolar damage that coexists with this obstruction in the small vessel. So we need to take into account, because everything is a little bit interrelated and have common, I mean, interplays. Capnography is also interesting when there is nothing, when there is no alteration in perfusion, but there is geometrical, in that case, alteration such as asthma or COPD. Because in that conditions, the alveoli remain with positive pressure at an expiration because there is a severe flow obstruction here. In that situation, there is a continuous emptying of CO2 in the airways, air in the airways, and this air in that alveoli has, in that case, a high PCO2 because there is the obstruction. And in the waveform, in the airway, the transition from phase 2 to phase 3 has disappeared, and even the end-tidal can be, in that case, I mean, higher than the arterial, because this will represent the continuous influx of, in that case, venous mixed PCO2. I mean, to the airway. So this is the pattern of the COPD, asthma, or airflow obstruction. Again, going to a patient, and this is a nice diagram of a patient with asthma on the day 1, you will see that, I mean, the transition is lost from phase 2 to phase 3, and when there is the treatment, corticosteroids, bronchodilators, whatever, is doing their effect, I mean, the waveform of the CO2 as a function of exhale volume has regained its normal function. So again, there is another marker that at the bedside, it tells important information. Just to I mean, to be a little bit more complex on that physiologic description, we must go to the first analytics, in that case of data space, going to the board approach, which takes into account only the CO2 as a function in that case of as a function of volume, without taking into account the shunt component of that space, which is when we take into account the PA CO2. Therefore, the big advance on the data space, in that case, identification or measuring at the bedside, was provided by the Enghoff modification of the Bohr equation, which takes into account, I mean, the mean expired CO2, and it takes into account the arterial CO2. So it takes into account the shunt component, and in that case also the data space component, which that happen in the majority of patients with RADS. The formula of the physiologic data space is the arterial CO2 minus the mean expired CO2 divided by PA CO2. And again, we must think all the time that the physiologic data space is subdivided into anatomic data space and alveolar data space. And again, anatomic data space, it's something that I will commend because it has importance in that case at the bedside. Just some reasoning about CO2. CO2, since it is approximately 20 times more diffusively across tissues than O2, so it makes it highly perfusion sensitive. Therefore, impaired CO2 excretion probably reflects the magnitude of microvascular injury, regional lung overdistension, and perhaps pronounced pendulum motion and a stunning at the alveolar level. That's why now in many investigations we take into account estimates of data space, or in that case the measure data space, not because for itself there is information for itself, but all this needs to be taken into account together with the other physiomarkers, in that case that we have at the bedside in the ICU. Since it's highly diffusive, some authors has just published interesting patients saying that if we are altering, in that case, the setup of the ventilator using, for example, long pause or short pause, when we are using long pause, there are more time, for this CO2 to be eliminated and the PA CO2 go down. It goes up when there is a short pause, and when long pause is restituted, then the PA CO2 again, it goes down. So CO2 elimination can be enhanced by a pattern of ventilation that prolongs the time available for gas distribution and diffusion within the respiratory zone. And this is particularly very important in that case for CO2. Another example, it relates with, the by the end inspiratory flow, whether, has these two patterns. And again, increasing pause or increasing end inspiratory flow has an effect on CO2 as a function of volume. If we take this graph, which goes in that direction, it can be increased, in that case, CO2 elimination by increasing the pause, or, with a high inspiratory flow. So these are aspects that at the bedside, it gives us physiologic information, sometimes very subtle. And let's see some waveforms. This is a tracing of one patient in the ICU. This is esophageal pressure, CO2 flow, and airway pressure. And patients breathe as they breathe, so they don't breathe uniformly. So they have different inspiratory times. But in that breath, the inspiratory time, it takes longer, 1 second compared with 0.7. And look at what the entitled CO2. It increases, in that case, a little bit. And this is simply because there is more time for CO2 to diffuse. So these are, curious, small, perhaps important physiologic aspects that we, at the bedside, if we, to understand the complex physiology of the patients on mechanical ventilators. When all the studies, when they compare, in that case, mechanical ventilation in RADS using inverse EA ratio, so longer inspiratory time compare, in that case, with longer inspiration than expiration, we will see that the PaCO2 in that patients in pressure control with inverse ratio ventilation goes clearly down, as you will see here. But I mean, clearly also there is a hemodynamic, derangement and the creation of autopy. So this probably relates, this decrease in PaCO2 in this prolonged diffusion time for CO2. An important aspect. These are the physiologic consequences of high data space at different, in that case, minute ventilation. So if we have a CO2, let's say a CO2, CO2 elimination of 200, okay, or production, okay, whatever, but fixed. And then we have a fixed data space of 0.7. I mean, to get a PaCO2 of 40 millimeters of mercury, we need 13 or 12, in that case, liters per minute here. But if we want in that patient to target, I mean, a kind of protective mechanical ventilation, which will account for 5, 6, or 7, in that case, mLs kilogram tidal volume, then the PaCO2 for this fixed data space at this VCO2 production by minute, okay, this will be at 60 or 80 millimeters per mercury. So this is important because this reflects the profound alteration in microcirculation in the lung together with shunt. And again, we need to think in that case on the different components of the data space. And this is important because the impact of the airways data space, it's important. This is a recent publication of an issue that we know from the past, but this has been characterized by the group of LLuis and Blanche. What we have here in red is, in that case, anatomic data space, and these are centimeters of airway data space, this tube, and the heat and moisture exchangers compared with the heater humidifier. If we look at here, this is the isovolume minute ventilation, and here the open circles is when, as you will see here, there is no other centimeters of instrumental data space, no other the heat and moisture exchanger, and then in this tracing here, it is the maximum when 95 milliliters of instrumental data space plus 20 due to the centimeters. If this is the tidal volume is 5 or 6 mLs per kilogram, this accounts for a lot on alveolar ventilation. When from here that was removed to a situation where there is no added instrumental data space, the alveolar ventilation improves. Why I'm saying that? Because during lung protective ventilation, this needs to be taken into account. So let's see a couple of examples. These are spontaneously breathing patients, and then we are looking only in that case, instrumental data space. Look at, this is a heat moisture exchanger where alveolar volume is 3.7 and do not vary, but in black is the minute volume due to, in that case, this increased anatomical data space. Again, this is for a lower instrumental data space, and here for a heat and moisture exchanger. The volume decreases at the same, in that case, alveolar volume. So we need to take this into account to remove this extra instrumental. Is this important? Yes, again. In patients with RADS, this is one of the first papers on expiratory washout, let's say, kind of tracheal gas insufflation, when the group of Jean-Jacques Ruby tested in patients with RADS in control when they use this type of tracheal gas insufflation, which is a kind of fresh gas to remove, in that case, instrumental, let's say, to clear CO2 in the instrumental data space. And then here is the optimization of mechanical ventilation. Optimizing mechanical ventilation will be removal instrumental data space. Let's see, that the PaCO2, which is here, decreases from almost 90 in that case to, 64 or 63. So this is very important because this is an easy measure that we can do at the bedside to improve ventilation in these patients. Let's talk a little bit about recruitment. This is the seminal paper of Peter Suter. Peter Suter clearly demonstrates that the best PEEP is the one that, improves physiologic data space, improves compliance because there is recruitment. So it parallels the improvement in data space, do not touch, in that case, cardiac output, and improves FRC, and therefore, as a consequence, oxygenation improves. Here is an old paper of my group. We were really young, we were residents, and we studied in patients with RADS. We performed the old classical pressure volume course, and we published that when there is recruitment reflected at this inflection point that we set PEP here, PEEP here, so the compliance improved, the gradient of PaCO2 and tidal CO2, in that case, decreases. And in patients, when there is no inflection in the PV curve, the gradient did nothing. So this gradient, in this way, or end-tidal as a function of PaCO2, reflects us, in that case, improvements on Chan. And if there is an improvement on Chan, the gradient in that case decreases because there was recruitment. But this is in a selected group, in that case of patient. Then other investigation, including ones from our group and the one from the group of Bjorn Johnson, show that going from PEEP 0 to 15 on average, there is no effect on physiologic on alveolar data space. It means that it is not useful, probably not, but it needs to be taken into account together with other parameters. The same in the big paper in New England from Luciano Gattinoni, when they study two types of patients, when there is lower amount of recruitable lung or higher amount going from 5 to 15, almost no variation in data space in these two groups. Again, that means that there is a lot of heterogeneity when we are, studying data space on recruitment. However, in animal models, when RADS is induced by, in that case, by saline lavage, which is a very recruitable lung, this is a perfect model to study the effect of PEEP or recruitment in data space, not only in physiologic data space, but in their components, alveolar and airway. This is a plot of alveolar data space, and this is PEEP, and this is Chan. When at PEEP 24, there is, no Chan, and there is, an improvement in alveolar data space. When the PEEP is decreased, the lung collapses in that case again, and Chan in that case increases and also increases alveolar data space. But look at this dot here. This is physiologic data space, because at high PEEP, there is an increase in airway data space and a decrease in alveolar data space. And when the PEEP is decreasing, these two combined effects has, let's say, a less important effect on physiologic data space. And we at the bedside, we used to look at the physiologic data space. Maybe that's why, we are not seeing the effects of PEEP on alveolar data space. I take that paper in respiratory care of Feng Mei because they do a kind of a standardization before analyzing the PEEP trial. And the standardization is doing a recruitment maneuver. So they do a recruitment maneuver, and then they, decrease PEEP in order to find the best PEEP in terms of what? The best physiologic data space. And here, the best, in that case, compliance. And then they set the PEEP in that level. If this can be found at the bedside. This is an excellent tool combining not only respiratory mechanics, but this kind of physiology of gas exchange to set, the best PEEP. Of course, we need to see the driving pressure, the consequences of that, but the combination of these two is quite interesting. And now at the bedside, the complexity of this is quite obvious. This is on the times that we were using Paratren. Paratren was a complex device to be used, but it provides very important and interesting information. This is a patient with a human RADS, and this patient is a responder to the recruitment maneuver. Oxygenation was, so poor. We did a recruitment maneuver, and then this patient improved oxygenation. The lung was completely open, and look at PaCO2. It decreases. Why that? Because in that case, it improves. Recruitment improves the BQ of these different areas. However, this is another, and then, at same respiratory rate and tidal volume, I mean, physiologic dead space, that case decreases. But at the bedside, we have, again, another patient like that. This is a patient where, I mean, there is a moderate increase in PaCO2. There is a derangement in oxygenation. This is, I mean, in the first 72 hours of RADS, this is the Murray lung injury score, which is, I mean, very high. And this patient is ventilated with a pressure control 35, PIP 18, and then we try to open the lung. And look at what happened here. I mean, we did not succeed to open the lung. We overdistended the lung. And as a consequence, then after, let's say, almost an hour, the PaCO2 remained high. This means that Shan was high, Shun, I mean, was not improved. And in that condition, I mean, this patient, I mean, probably deteriorated the lung function due to this aggressive maneuver. So at the bedside, we don't know. This is one of the major drawbacks of the recruitment maneuvers, in my opinion. So again, at the same respiratory rate and tidal volume after a recruitment maneuver, I mean, physiologic dead space increased, and probably, I mean, we did not good on the outcome on that patient. Prone position, again, is interesting because in that condition, we have evidence that just turning the patient, sometimes the PaCO2 goes really down, and this is because we have improved the BQ of patients in prone position. That's why prone position, even, I mean, if there is a small, I mean, improvement in oxygenation, we need to look at the PaCO2 because probably is a marker of outcome, such as, I mean, described in that paper. This is an old paper from the Gattinoni group, when they separate the patients by CO2 responders or non-responders in prone position. And you will see here the patients, the percentage of patients, and the response to the PCO2. There are some patients that it increased, and in some patients it decreased. But in the ones that there were responders, where the PaCO2 decreased after proning the patients, the survival increases in that patient, whether the survival do not, I mean, improve in the non-responders. Again, saying that if we recruit the lung and we are able, in that case, to improve the BQ and, I mean, and to have less driving pressures, much recruitment, much better distribution of BQ in proning position, which is one of the major effects. Also, this has, I mean, an effect on outcome. And this paper is interesting because this is the one in the literature that, I mean, combines, in that case, the measurement of that space, in that case, the Enghoff index, as a function of the driving pressure. And it is interesting because when the driving pressure, when we, let's say, as an effect of increasing PIP, the driving pressure, I mean, increases more than the 15%, let's say the driving pressure is not decreasing, the lung is more overdistending than recruiting, there is an increase, as you will see, in the Enghoff index of that space. And when the driving pressure, I mean, this increase is less than 15%, probably in that case recruiting, there is a tendency to improve, in that case, the dead space. So another important information at the bedside, because if we are going to recruit the patient, we need to look at, I mean, different physiologic markers, and, I mean, measurement of dead space should be one of them. So in patients with RADS, increases in PIP result in higher dead space only when associated with a parallel increase in the driving pressure. So let's talk a little bit of outcome. This is a first paper of Nacton when they measure, in that case, dead space, and they found a clear correlation of dead space fraction and mortality in patients with RADS. So more dead space, more mortality, and then the mechanisms, they said that probably injury of pulmonary capillaries by thrombotic or inflammatory factors, obstruction of blood flow in pulmonary circulation or lung areas with high BQ, because then the CO2 excretion results impaired. After that, there are other papers, and this one is particularly important because the situation is completely different before and after the era of the lung protective ventilation. Before the era of lung protective ventilation, I mean, a marker of survival in patients with RADS was pulmonary hypertension. However, in the area of lung protective ventilation, systolic pulmonary arterial pressure is no more a marker, and it is a marker of the data space fraction, again, in this series of that paper. And keep going on that. This is an interesting, from Joan Maria, investigation saying that mortality and data space fraction in these patients with RADS and with early and intermediate RADS. And again, it seems that also there is a nice correlation mostly in that case in intermediate RADS about mortality and data space fraction. Since RADS is a syndrome, it is wise to study, the different entities causing RADS. And it is what has been done in this paper of Rich Khaled, where, different types of RADS, aspiration pneumonia, sepsis, trauma, let's say, pulmonary, extrapulmonary RADS. And again, it seems that there is a difference between non-survivors in white and survivors in red. Always, that the space is higher in that case in non-survivors. And again, it seems that there is a correlation between mortality in RADS, with the exception that in mild RADS, that space failed to distinguish between non-survivors from survivors. And it does in intermediate and severe RADS. So in order to find, some kind of algorithm that could help us breath by breath at the bedside, we investigate what is called alveolar ejection volume, which is a type of mathematical arrangement of the CO2 elimination, in that case, as a function of expired volume. Because we fit a kind of equation to here, and then we measure, the separation of this fitting line from the CO2 as expired, CO2 elimination as expired volume in that case line. So this gives us an index, which is alveolar ejection volume. And then we found that when this index deteriorates, as from admission to the 48 hours, and it show the patients where, they are going not to survive and to die with this specificity and this area under the curve. But interestingly, we also measure physiologic data space from admission to 48 hours, and also physiologic data space predicted also survival. What's the difference between physiologic and what we call VT is that this can be measured breath by breath using a computed analysis from CO2 as a function of volume, if all these are collected by computers. And again, this it's important because trying to find at the bedside index that can be easily measured, not a little bit complex of the Enghoff measurement with, it must be done with a sample of, in that case, of arterial PCO2 and some capnographic measurements. What Khaled again and Lipnick, measured was the relationship of end-tidal as a function of PaCO2, just that. First of all, they find an excellent correlation in that case between, physiologic data space, as you can see here. And again, when they look at these different fractions of end-tidal as a function of arterial CO2, they say this nice, in that case, correlation. And again, when they look at the using, a mathematical model, the predicted mortality and in the PaCO2, in the end-tidal as a function of arterial, they found that every 0.01 increase in end-tidal CO2 as a function of PaCO2, mortality risk decreased by 1%. So this is an index that can be easily computed at the bedside each time we get some arterial gases that may help. So in multivariate logistic regression modeling, both end-tidal and PaCO2 and ventilatory ratio remain independent predictors of mortality after controlling for other variables. Trying to find estimates, not measure, but estimates of data space, the group of Sinha and again, Rich Khaled, studied the ventilatory ratio, which is an index of lung efficiency, reflecting again the relationship between measured and predicted PaCO2 and minute ventilation. This is done by this, easy equation, minute measure minute ventilation, measure PaCO2, and then predicted ideal body weight and ideal 37.5. So the ventilatory ratio measured in that way was independently associated with increasing risk of mortality after adjusting for a PA, for oxygenation, PEEP, and for severity. And looking specifically data from that study, this is physiologic data space, this is ventilatory ratio. Again, nice correlation here, as you will see. All this is significant, but this is not significant with oxygenation. So oxygenation is not a marker in that case of prognostic in patients with RADS, but it is the ventilatory ratio, and not only it is a prognostic, but also the probability, to remain in mechanical ventilation is higher in the patient with higher ventilatory ratio compared with patients in lower ventilatory ratio in two different cohorts. This is the testing, and this is the derivative cohort. So this is a very interesting paper showing, again, that these physiologic markers at the bedside provide important information. Again, trying to find, in that case, estimate of data space, Beyblade and co-workers tested 4 types of estimates of data space, the classical from the Harris-Benedict equation, the Siddiqui, the Penn, which is different, and the direct estimate, which takes into account a lot of, it's a kind of mathematical model of a lot of variables, and again, the one that best estimate, in that case, from the tool, let's say, the measure, which is the gold standard versus estimated, was the Harris-Benedict. So the best performing estimate predicted measure data space fraction within plus minus 1.10 in only 7/10 of patients, and 0.2 in that case in 95% of the patients. Let's say that, okay, it can work, but still the best, at the bedside is the measure. And this is, in the quintiles of the measure in black, and all the 4 estimates, to predict, in that case, mortality. Again, Harris-Benedict estimate closely approximate this association with mortality in the same core and remain independently predictive of death in this larger RADS and network core, and the other 3 predicted less. They were, they predicted less mortality. So if we do not have measurement, the Harris-Benedict is a good option. Let's talk a little bit on COVID-19 and the information that we have right now. COVID it's a new disease. I'm not going to talk about silent hypoxemia, but it's clear that when in the lungs there is increasing chance, because in that case there is loss of alveolar air. And COVID, we know that it causes the pulmonary intravascular coagulopathy, causing also, in that case, data space. These 2 combination of Shannon data space, leads to an increase in the respiratory drive. And this is very interesting because this increase in respiratory drive, maybe there is also some impact on the virus on the respiratory center. This warrants further investigation. Again, the drive, causes increase in effort, later on increase in rate and dyspnea. And these patients, this is one of the reasons that we intubate patients with COVID-19. This is just to remind that after, there are several phenotypes that there has been described, and still there is controversy, but some people believe that this initial state of interstitial pneumonia evolves of this, diffuse alveolar damage when there is this high inspiratory effort, maybe inflicting, in this case, further pulmonary injury. This is probably one of the major causes that these patients get, more neuromuscular blocking agents compared with non-COVID RADS, and it evolves to a pathological fibroproliferation. In that condition, I took from the literature this interesting paper saying that if there is microthrombosis in COVID, what happens if these authors induce fibrinolysis using this recombinant tissue type plasminogen activator. And this is what happened. This is before fibrinolysis. This is the percentage change. And you see here data space and also PaCO2. And the time after treatment with, recombinant plasminogen activator. See how that space goes, in that case, down. The PaCO2 goes down. At the time, oxygenation, in that case, improves. So these are cases, only cases. This is observational, low level of evidence, but it is, interesting that behavior that remembers this all patients treated with pulmonary emboli, and in that case with also fibrinolysis that I described before. The first report of ventilatory ratio in RADS was done in March 23, 2020. And it was just a report saying that in patients with low tidal ventilation, ventilation ratio is 2.1, and when this tidal volume was increased without, as you will see here, a dramatic increase in driving pressure, ventilatory ratio in that case goes down, and this in another cohort of patients at this intermediate tidal volume also in that case went down. This is interesting because it's the first reference saying that if the COVID-19, there is a lots of microthrombosis and there is pulmonary derangement in the pulmonary vasculature, maybe this is a good indicator. So again, this is in patients with COVID-19. This is a large series of these almost 200 patients that, corrected, in that case, minute ventilation, was done. And they compare this with, estimated VDVT and ventilatory ratio. And again, this predicted, outcome. And also, author said that perhaps this indirect measurements or estimates of pulmonary dead space could serve as, to stratify severity in this type of patients. More a little bit about that. This is an interesting paper of this Italian group. In two cohorts of patients, they compare COVID-19 RADS and non-COVID-19. And these are, I believe, high numbers. And it is interesting because the non-COVID, they were more severe, but the mortality clearly was less. But then when they examine respiratory physiology, and let's go here to the ventilatory ratio, in the COVID-19 was higher compared with the non-COVID RADS, perhaps reflecting this alteration in the pulmonary vasculature. When they look at the VDVT estimated also, it is the same, and corrected minute ventilation also, in that case, it is the same. The same happens for PaCO2. Again, this is a physiologic marker that it maybe should be added when, in that case, professionals titrate PEEP, or for, in that case, the stratification and the follow-up of this type of patients. Looking in these density plots, clearly in COVID-19, corrected minute ventilation, in that case, is higher. No effect in these two cohorts in compliance, and more heterogeneous effect on PEEP. The mean PEEP in this COVID-19 was 12, and in non-COVID was around 8, but more heterogeneity. So again, estimates of dead space maybe are useful in this type of case. Gattinoni on this was done. This is one of the earliest publications about COVID. He said that recommended end-tidal CO2 as a function of PaCO2 relationship as a useful tool to quantify efficiency of pulmonary gas exchange in the days incoming. For what reasons? Again, shunt and dead space, because a little bit it combines both. So it is again interesting. So this is a paper that I participate in a huge series of COVID-19 patients in the Netherlands. So the difference in that paper is that, again, these are estimates of dead space, the dead space fraction, Harris-Benedict, the direct, and the ventilatory ratio, and the end-tidal, but studied on the start of ventilation up to day 3. And interestingly, these do not predict mortality, but it was useful to track the evolution, in that case, of the survivors and the patient of non-survivors. However, when end-tidal as a function of arterial CO2, was in that case analyzed, it was a predictor of survival, as you can see here. So again, if end-tidal as a function of arterial CO2 reflex, shunt, and data space alteration because it combines both. So it is interesting because it was significant in that paper. So again, this is an interesting letter in chest. Let's say that decrease data space before going to ECMO. And this is clearly what happened. If this patient here is ventilated with a protective mechanical ventilation, which is low tidal volume, 5.1 mL per kilogram, but has this amount of instrumental data space, which is 5 plus 5 plus 5 plus 60 plus 30 plus 18 plus 5, it means that, I mean, half of the tidal, not half, but 40% of the tidal volume, it's for just moving air in this instrumental data space, causing a dramatic increase in PaCO2 and a decrease in alveolar ventilation. Going from, removing all this will increase alveolar ventilation from here to 9.2, and probably this PaCO2 of 90 will go down, improve, to a certain amount, improving PaCO2, but also improving the hemodynamic and other conditions of the patient. So always look at this instrumental data space. Just to finish, this is not new. There is a preliminary case report in the 69 saying that washout of anatomical data space for alveolar hypoventilation, and I add here, remove anatomical data space for alveolar ventilation. Just to conclude, these are some editorials that I had the opportunity to write, and said that if data space is not integrated and analyzed together with data coming from other physiologic monitors, their clinical meaning could be incomplete and even misleading. So take everything into account. Data space in RADS must be understood a physiomarker of severity, and management should aim to protect the lung from overdistension while maximizing recruitment to avoid further increases in tidal volume. Also, measured BDVT, can be used as a prognostic in that case indicator. And I wrote at editorial in this paper of Khaled and Sipka, okay? And I said, despite of a myriad of physiologic measurements available at the bedside, diagnosis and stratification still relies solely on the assessment of oxygenation. And this needs to be improved because we have many other markers together with oxygenation. Oxygenation is a consequence of what we see in the other biomarkers. My last slide. This is our 5th intensive care unit that we built in 8 days. This is the 3rd week of April. This was an empty building. You will see this is empty completely. So we put, suctioning, 2 lines of oxygen, 1 line of air, an internet connection for this connectivity that we connect all monitors and ventilators. This is just to say that the pandemic, put, professional on the edge, cost a lot of lives. We improve science, and probably we increase our digital transformation of the hospital. This is a slide of a recognition for the huge work and professionalism of the nurses, the therapists, physicians, engineers working, all people working at the bedside. So it's a kind of homage, to him. Just that. Thank you very much.
Thank you, Luis. Thank you for the presentation.
Great talk.
And thank you for the homage. Would people like to ask questions?
Yeah, I have a question. Can you hear me?
Yeah, go ahead, Robert.
Yeah.
So that was a wonderful talk. It's probably the best talk I ever saw on that subject. Great slides. You could read them. They're colorful and beautiful. My question, though, is, does the Better Care system have any artificial intelligence algorithms to interpret volumetric CO2?
We have the alveolar ejection volume, and we have measurements related to CO2 as a function of volume. That was one of the first measurements, but I must admit that for online, so for real-time measurements of CO2, this is quite tricky. So because there is delay, sometimes, synchronization is quite difficult. it takes time from the different types of capnographs. What can be done is offline. Okay, so we can see CO2, but online measurements are difficult. So then we can measure Untitled. We can measure, in that case, if there is CO2 as a function of volume, we can integrate. We did some work in the past, but now we are not using that type of data for one reason. We do not have, CO2 in the patients in the ICU. I mean, physicians don't use CO2. Is something that maybe because there is an increase in instrumental data space, maybe because they don't interpret what's going on. But to me, this is a fascinating physiomarker in that case at the bedside.
Yeah, I agree. We don't use it either, even though we have NICO monitors. Very few of our clinicians know how to use it, much less interpret it. So it's a big opportunity, I think, that we're starting to look at.
Since we integrate all kind of waveforms coming from ventilators, when CO2 is there, we can easily have CO2, synchronize it with everything. But we need to do some streaming, and then the engineers, it's a tough work. So it can be seen. It can be in a workstation. We can have the output of that analysis very nicely, because the delay will be in 2 or 3 minutes, which is not important at all. But for online measurements, online calculations, it's a little bit tricky.
Can I ask? It's Andreas here. Sorry, I was just 2 minutes late. Rob, you mentioned artificial intelligence, and if you look particularly in ARDS, the different predictors. There's not just the CO2. We look at PF ratios. We look at driving pressure, tidal volumes, etc. And what you said in your just last few sentences is that for the less experienced clinician, it becomes very complicated, because you've got 5 or 10 different predictors that are quite complicated to understand if you're not very savvy in understanding all of the lung physiology. And since probably 95 or 99% of the clinicians probably would require them a few hours to understand all these different ratios and indices, I'm wondering if some of research effort should go into helping the clinician with artificial intelligence to integrate these factors and understand to which group is the patient actually belonging to. Because first of all, understanding the indices is high brain power, and putting them into clinical context requires expertise. And then there's the time factor. We simply don't have the time to spend and analyze, because the next patient needs care as well. And particularly, as you showed in your last slide, in a busy unit, you can forget the most sophisticated predictors. They're simply not going to be used because you don't have time.
Yeah.
And I wonder that the future of ARDS research should go along using artificial intelligence model that help the clinician to assist, to integrate and synthesize the knowledge that we have gained with these fantastic physiological studies, but we just simply can't apply them in clinical practice. And there would be a very nice plan for the future, that you look clinicians supported with artificial intelligence versus clinician not supported with artificial intelligence. If that's what potentially could change outcome in ARDS, because there are too many factors to consider that we can cope with them on a simple clinical basis and in a busy unit.
I fully agree. Not for data space, but this is for asynchronous in patients mechanically ventilator. This is we are working on artificial intelligence on asynchronous and trying to provide I mean, not to understand all kind of physiology behind, I mean, asynchronous, but at least to detect the ones that we consider that there are injurious and how them perform in clusters, okay? So now we are thinking how to report that in a way that could be useful in that case for clinicians. So I agree with you. This is fascinating. I am convinced that not many indicators, but clear and some indicators that we can explain to the clinicians exactly what they mean and what they must do when they when they are repeating and repeating. This probably will have an effect on outcome, but there will be a little bit of resistance to change on that. It's because I am suffering this. It's so the digital transformation and all this in the ICU, it's going slowly a little bit.
Hey, David, I know you were going to leave at 5:30. Do you have any questions for LLuis?
No, it's because I've spent a lot of years thinking about lung distributions and ventilation perfusion relationships. So it's interesting to see that people still haven't solved the problem, but it's a good beginning. And I think that a tool that's at the bedside that people can use fairly easily on a real-time basis to measure something of lung homogeneity would be very useful in trying to figure out how to ventilate patients. So I think this is a very interesting talk. I appreciate having the opportunity to listen. I am sorry that I do have a hard stop. Steve let me know a little late, you know.
Thank you.
Let LLuis know a little late. Yeah. Okay, well, thanks, guys. Patrick, do you have any questions? Or it looks like Jeff might even be primed to ask a question. He had that look again, that synchrony look in his eyes.
I would find this, thank you very, very much, Louis. It's an extremely good lecture. And I am always looking in situations where the patient is really undergoing very rapid changes at the bedside. I'm just really scratching my head. What can I interpret from this? Patient's got a very fast respiratory rate, spontaneous respiratory rate, and a lot of things are going on in my mind. And all these illustrations have brought back just how important it is to try and integrate the information. And I look forward to the idea that actually we can get better tools in the future with software that will help us in this task.
Yeah, I fully agree. I fully agree.
It's Jeff Shaw here. Great talk. Thank you very much. Yeah, I'm just reflecting on the knowledge gap, really, including my own. We don't have technographic CO2 in our ICU, so it's something that we don't use. We just have the Untitled CO2 and, look at that and sometimes wonder about alveolar dead space, if you might be able to infer from those things. But the real problem, really, I call it, is the knowledge gap. And that is that for 99% of the time, the ventilation, at least in Australia, New Zealand and the UK, is driven by the nurse at the bedside. And we have great difficulty even educating some of the nursing staff about some very obvious things, such as ventilator synchrony, or, it's not uncommon to wander by and look at a ventilator and look at the settings. You think, my God, how can you stand here and look at that patient? So I wonder if this is just talking around the subject, but I think we've got some there's a lot of work to do in the most basic understanding of how we ventilate patients. And we need to have, I think the answer is some form of artificial intelligence or expert systems that tell us all the time in real time how we're going without really having to interpret and think about things in the way that you would do if you were listening to a lecture and trying to understand bits and pieces that's going on. So I wonder if that is going to be the next thing that we need to look at, is at the human level and how people understand this information and integrate it and then change the clinical practice. So I just think that until we start to get changes that occur all the time, in real time, then all the good that we do from a few patches of absolute brilliant interpretation of the pathophysiology in the patient will be completely flooded out by, if you will, very poor ventilation practice for the other 99% of the time, if that makes sense.
Yeah.
Yeah. I mean, I agree. I mean, I remember a paper where, I mean, they tried to find some kind of a yellow, green, or red according to the patient is okay in terms of tidal volume, which could be the same in asynchronous or lung homogeneity, maybe. Yeah? So, and they succeed because they do not interfere on the work, and that was a big screen, okay, as a kind of a big screen saying that this patient is maybe in I don't know, not in red, maybe in yellow, and something is going there and some recommendation, which allows the professional to go there and also allows to think a little bit, because the physiology at the bedside, the physiology of the patient being mechanically ventilated, to me is one of the most difficult things in the ICU, perhaps the most difficult thing. That's why maybe there is a lot of, as you said, different indicators that we need to take into account. But there are some that clearly may cause damage. And maybe we need to have a kind of the way to show to the people in order to do something. I don't know, but this is clearly a work to be done.
I'm just thinking about that. We have a number of checklists that we go through. LLuis introduced a very famous one, the fast hug. I think that's probably used by most ICUs throughout the world. But it might be possible if we get a group of experts together to have a ventilations checklist. At the moment, all we have is 6 mils per kilo, and that's it. Why don't we, do you think we could work together and have a checklist and that actually picks out some of the advanced physiological stuff that you may or may not have, but even some very basic stuff that you just go through and you just see whether or not the patient is actually compliant with that. And that would at least, would educate us and also give us some sense of what's important. And then we can audit that. We can audit how compliant we are with these checklists. Because I really think that one of the problems with ventilation research is at the moment we've reached almost like a brick wall, or a glass ceiling or whatever. Is that unless we can change people's behaviour and we can penetrate that, then with all the goodwill in the world, we're not going to make a lot of difference. What do you think about something like that with a ventilation checklist?
Well, the ventilation, it's okay, but it needs to be based on what's going on in the patient. Okay. So a checklist of 6 mLs per kilogram, maybe it is not appropriate 6 mLs per kilogram because there is a lot of instrumental data space. Or maybe that patient with 7 mLs, it's the best driving pressure, the whatever, and you know what I mean. So, I mean, the checklist covers a part of all that, okay? But, I mean, always the experience and expertise must be around the evidence. Perhaps I am controversial about that. Evidence is okay, but we need data from other sources. Okay, experience is one, real world data is another one, clinical trials is just fine, and now we know that high tidal volume kills, but low tidal volume, 5, 5.5, 6, 7. I mean, there is an adjustment there. Okay, and can this be done by artificial intelligence? Because it takes into account all kind of expert thinking. And we are nourishing all these neural networks or so. Maybe yes, in the future, but this needs times and needs connectivity and data integration. This cannot be done if we do not integrate all monitors and all ventilators in the institution. And then we link that with the medication. And for example, we link that with heart rate variability. which is quite common in COVID, and we cannot measure that. So to me, there is a lot of, we need this type of digital transformation of the monitoring before we can think in going further with the checklist you are proposing. But I agree with you. The checklist saves lives, probably.
Yeah, no, I think that's a really important point. We need a transformation in digital monitoring. We must make all the monitors and ventilators agnostic. And so I'll give you an example. Let's say that I'm in a small ICU. We're not expert in any of this, but we could actually give you our ventilation data with a agnostic monitoring systems, and we've got volumetric CO2. We've got all our ventilators set up. Somebody could come in and they could look at our data and whatnot, and they could tell us how well we're going, and we could get direct feedback. Because for the first time, somebody else is actually looking through an appropriate window at what we're doing.
Yeah.
It's that sort of quantum leap forward that I think we need.
Let me go a little bit further on that. Perhaps the solution is, that hospital, a small ICU, to be connected with a big hospital where all this information goes to an expert that understands that. But this is not such as, the actual telemedicine. You need the information of what's going on. And the actual telemedicine is watching the TV. So it's a camera, on the monitor. But you need to see the everything on the patient. And then an expert can answer these let's say, advanced questions that will improve, will improve the prognostic of that patient there. Well, we need to think about that, because it's we need to. It's not only at the bedside to understand. There are more on that.
Can I give you an example? Probably an easier, more confined area is neurology and EEG interpretation. They're going now very clearly down the track of EEG reading analysis based on AI, and gives the bedside nurse, you green, orange, red, or whatever marker, and then because the neurologist is not going to be around, no one can actually read an EEG. I can't. And that's exactly the same. They're saying, okay, when the red flag is coming, help is needed from and by an expert. And they're going, these continuous EEG machines, they're giving you these tools now, and they're using them because they clearly detect that the time spent in seizures, time to intervention has reduced. And so similar, it's much more complex what we're looking at, because we shouldn't just only look at ventilation. We need to look at, cardiac output, all the rest around it.
Agree.
But I think it's a huge task to start applying artificial intelligence into that type of treatment. But I'm strongly believing interpretation of all the results that we get from the monitoring is beyond what an average clinician can do. And I've got a good friend of mine. He's a Qantas pilot. If they were to monitor all the signals as we do, coming from all the valves and hydrostatic pressures and whatever, the pilot would be completely overwhelmed. They only get into the details once the alarm is telling there's a problem in that type of system, but they can't monitor all the systems. And so in aviation, they already use that type of integrated alarming based on the knowledge what's right and wrong, and then the pilot is the gatekeeper.
I fully agree. We need few good integrated indicators. Fully agree. Fully.
Just to give you guys an idea of how the ventilators, building a ventilator works and what has to be conceived. Currently, there are ISO standards that tell any kind of medical device how to respond with an alarm and what to do in those alarm cases, and they call out colors and things of that sort and use the signal light approach in many cases. The issue comes, though, is that when the standard is interpreted, the manufacturer has to decide what is a root cause and what is a secondary alarm and these sorts of things. So in that compliance and interpretation, I think that's where you don't have uniformity. And I think it would be helpful if the medical community gave guidance to what they felt was important to the manufacturers, so that there aren't product managers in offices with, never seeing a patient, figuring out what is a high priority alarm and what is not. And I think that those, that's what's going on now. But I had another question related to where we have that feedback. Right now, the information within the ventilator, as Graham and I often say, is enormous. And when you have integral monitors, it increases it. Where do you guys want those alerts? What we typically call is the yellow is kind of an alert. It's not really a get over here and a patient's disconnected or anything of that severity. Do you want those kind of guidances and alerts to be coming in the ventilator so that the caregivers at the bedside who are attached to the ventilator per se get that guidance? Or do you want it to be transmitted out to a expert system that sits maybe for the nurse, the therapist, the physician, for everyone to see kind of a trend of what's happening? Where do you want that information?
Well, I think the first thing is that we have to get away from threshold alarms. You're never going to get high accuracy of what's going on in the situation if you just set a high and a low value and alarm above and below that. They have to be integrated, this sort of Internet of Things, as we've been speaking about here, and there has to be artificial intelligence applied, maybe fuzzy logic, I don't know, but you just can't keep adding more and more threshold alarms and expect to make any sense of all this.
If I jump in here, and I'm just looking at Rob's background, looking at his 3 waveforms, right? And you can put more waveforms on your 5 waveforms, you want 8 waveforms. And what we know is that I would say 90% of people look at that have got no real clue what it means, right? Like you say, you're walking like Patrick said before, you walk in the ICU, patients working like hell, but nobody's really understands that. And as you can see behind me, the way we try to work on that is a different approach of how you integrate information differently. And one of the ideas I liked was how you could even change colors or change shape. So the user had an idea if green was good, but orange was, showing change, or red was bad. So people, you could do that if you could integrate that type thing along with CO2 somehow. So you've got half the message, which is lung mechanics or muscle work, but you also put in CO2 into that picture. That could be very useful for the clinician to understand what's going on.
Graham, the issue and what Rob just said is that these certain, transition between green, yellow, and red are maybe very different if you have a patient with poor pulmonary perfusion versus a patient with good pulmonary perfusion.
Yeah.
And I think that the expert who spends 15 minutes bedside and scratches his hair and thinks the whole scenario through is still the best approach. If you were to have an expert for 4 patients only per 24 hours, then that would work, but we don't. And I think this the multitude, the magnitude of data needs to be taken out from a machine. So going back to Steve, it's not the machine, the ventilator, it's on its own. The information from the ventilator needs to go in a central analysis tool that helps then to integrate the data. But this central analysis tool needs to have information around cardiopulmonary and cardiopulmonary data as well, and input from the clinician, and needs to give you as well over time impression of what's happening, not just one point. Okay, alarm went off at that point, but it's harmless, disconnection, or it is a real problem. I think it becomes a very complicated, and I don't think we as humans, average human, can cope with the amount of information. So it's a big project that needs to go outside ventilation only. So I think it's not the task of the ventilator companies. It is actually the task of integrating all the disciplines into an AI system.
But that's what big data is all about, trying to capture a lot of stuff.
And I'm pretty sure it will come. It's our hesitance as clinicians. Do we trust the computer?
Yeah.
And we have a huge reluctance on these automated systems because we just don't accept them. We don't trust them.
True.
I don't. I mean, I'm included. You know, I think I know it better than an AI system, but we need to be proven wrong.
Ultimately, I think ventilators are going to be just dumb terminals. There's be a box of pipes, and all the intelligence will be located in a cloud somewhere, and every ventilator can learn from every other ventilator. That's where we have to go. We see this in other areas of life, right? The way cars learn and they drive us to work.
Yeah, I've scared a lot of people saying that really all we need from the ventilator is the valves.
That's ultimately where we're going.
To meter the system in, and let's put everything else into the central user interface. And, you know, I think of sports a lot. I'm kind of a fool that way. But in sports, they keep it simple. There's a scoreboard. There's goals to be achieved, and it's a few numbers. And it's easy for the team to process that. I wonder sometimes if we've done the opposite in medicine, where there's so many numbers and there's so many indices and there's so many things that you lose track of where you're trying to get the patient to. Don't know.
Okay.
Anyone else?
Just a comment.
Yes.
Just a comment on that. I believe that the big sound and the red light will not disappear in many, many years, okay? Because there are lots of regulations and things. To have a screen at the bedside will not disappear. But, I mean, to a second level is the ones that it appear in any device, like here, for example, okay? So I can see patients here right now, you know, with our web visor, okay, that we have created in that way. And then there is a third level, which is all this integration of this data, which is a huge amount of data, as you said before, okay, a huge amount of data, and see, I mean, what could be extracted there. And this huge amount of data in the ICU should go together with the data in the floor, data in the wearables, data in the chronic care, and all that. Now we are involved in a kind of projects like that. Let's see where we will go. But Halpern, it's describing this as the ICU envelope, the hospital envelope, the connectivity envelope, and then n times of this whole thing. I think we need to integrate everything, but just to play with a small amount of digested information as a form of indicators. Indicators for nurses, for therapists, for physicians, for whatever. And then all this data should be available for research, for future data analytics or whatever. This needs to be stored, but not used now. Is this for real world data to play, for all that? Because if not, I mean, we need tons of data to get all this artificial intelligence work. But then the analytics that will help the patients, and then what needs to act. I mean, there is a disconnection, we run. So, I mean, this should be a sound alarm. But for example, we just looking at the chaos behavior of the patient in the ventilator, and we think that we can predict unplanned extubations. That is for what artificial intelligence work. Okay, so if it is a chaotic performance, a chaotic means in terms of hemodynamics and plus the ventilator, and so, I mean, this is a kind of alert that perhaps the chance to an unplanned intubation is high. So this is an alert that should appear here saying, look, I mean, go there because this patient, the probability of having an unplanned extubation is increasing. Please have a look. Something which is kind, you know what I mean? And maybe in this way, we will differentiate this. And this is a good alert for nurses, for example, no? Because we need, well, I said nurses because in Europe and Spain, we don't have therapists, okay? And the work of the therapy is a combination of a nurse and a physician, okay? So it's not. Anyway, lot to do, lots to do.
Yeah.
I just wanted to respond to Jeff when he made a comment about a checklist and education. And I wanted to share with you guys that we have developed a checklist that helps people through a 3-step process just for evaluating patient-ventilator interaction. And we demonstrate this online to open to the world every 2 weeks. We call it Vent Rounds. It's on Tuesdays. I think it's 2 o'clock Eastern time. And if you want a connection to that, I'd be happy to share it. We also have written a paper on describing how this works. It's currently in review in respiratory care. But these are teachable skills. If you have a checklist, that's a good approach. And you have to have a step-by-step methodology. And like playing the piano requires practice with an expert mentor. So that is available, and we are working on it. I invite you all to join us. We also have a YouTube. We videotape these every 2 weeks, and we post them on YouTube.
Okay.
Excellent.
Anyway.
Well, thank you so much, Luis, for staying up late and helping to share and educate us. And we really appreciate everyone's time. Also, all you guys waking up early on the other side of the globe. And we look forward to doing this again. So breathe easy.